Antony, thank you so much for joining me. I have a question really for the audience who's a mix of women with diastasis recti, or have been told that they have diastasis rectus abdominis, and the people in their lives who are on a mission to treat this abdominal separation. So that might be your physios, your physical therapists, your fitness trainers, whoever out there really wants to know more about diastasis rectus. And I've actually been telling people ever since I've come across more of your work, you have to follow this guy as heavily as I'm following Antony Lo. And so thank you so much for joining from the Physio Detective. Antony, I have a question for you, and this is a really important one because you and I have actually never met. And I've done a lot of work more in the acute care setting and actually had a recent loss in my family where, young woman, 34 years old, died this past summer. And she had a very difficult recovery after her cesarean birth. And I advocated, of course, with the work that I do and with my background, that she have at least a physio or someone, physical therapist, see her in the hospital because she was using the bed to get up. And I got a call the next morning when she was discharged around 4 o'clock, was that she nearly took the newborn down in the cradle because she couldn't get up. And so it really struck me. Someone shared a post that you made about crunches after C-section. It struck me because that was so soon after her funeral. And she ended up dying from complications with preeclampsia. But it was so soon after her funeral and me processing her cesarean recovery that she needed a hospital bed as an assistive device. She wasn't ever, she wasn't taught to do crunches. And why aren't we teaching women to do crunches after C-section? Is something I've never taught anyone to do. And so I'm part of the pool that's probably really asking more of these questions. What are we doing with women really early after birth? And your work really brings me to my first question is, are we doing something wrong by making women wait 6 or more weeks before starting exercises after their delivery? That's my first question for you.
Yeah, thanks for having me on, Rebecca. And uh, I'm sorry for your loss. That's terrible. I don't think we're doing anything wrong. Okay, like the mere fact that there's a right and a wrong about it. Like, I think as clinicians, as professionals, we should be thinking about the advice that we're giving people. So, should we be prioritizing doing crunches? No, I don't think so, unless that's what the person really wants. Because if we're going to say that it's patient centered care, person centered care, well, then we should center the care around their goals. But it also doesn't mean that we should be irresponsible and unprofessional. So when it comes to crunches, for example, I've been doing antenatal, postnatal care for 28 years, right? Nearly 29 years. And it doesn't make sense to me why we can't do crunches. Like, people lift their head and shoulders to look who's come in the room. I don't know if you've seen that, but like, people will do that. They'll instinctively look to see who's come into the room. When I was working in the hospital system, like, people are doing it anyway. That's number one. Number two, what's the concern? Okay, so the concern is that we have a horizontal scar and then we have a vertical scar. And, the vertical ones are inside and the horizontal one is the skin and the subcutaneous fat. So, what is the movement that will open up the anterior scars? And it's going to be extension, right? Like, if you take a horizontal scar at the front and you crunch up, every person knows what happens to your skin when you do a crunch or a sit up is that all of that skin bunches up. It gets less tension on it. So, how exactly is this going to be a problem if the skin is getting less tension on it, on where the scar is? Now, it could be that there are people blowing out pressure through their tummy and the perineum, and that would be inappropriate. So, at least let's think about what we're doing and why we're doing it before we start saying you can't do it. So that's number one. Number two, the vertical ones, we can't see the vertical scars. So we think about it. Okay, what is going to open up those vertical sutures? The scar. And that's going to be excessive amounts of pressure. So what's that going to look like? It's going to look like distension anteriorly. It's not going to look like soft tissue that you can push. So Yeah, did I say that in a provocative way? I did, because it doesn't make sense to me. It doesn't match with what I've observed for 28 years. And like people do it anyway. It's harder to get out of bed in a log roll for many people than it is to get out of bed the way that I show them, which is using momentum to get to sitting. Why can't we use momentum to get to sitting if all the parameters that we're concerned about just aren't there? If they're not bearing down, if they're not putting pressure on their sutures, and if they're in less pain and symptoms, then doing it the harder way is log rolling and pushing up to standing, by the way. Anytime you push with your arms and you push your body weight up, I would argue that you may be using more intra-abdominal pressure than if you just maintained your shape and you use momentum to rock yourself up. So I'm just asking people to use their brains, and let's just take what we know. And instead of following what somebody says we can and can't do, like actually think about what's happening with the person in front of us, monitor, observe. And there are many people that this would be anathema to. So just see what happens when you lift your head and shoulders up on somebody who you feel comfortable with, and like just see, because it is not appropriate for everybody. This is not another, I'm not replacing a you're harming everybody by stopping them rule with you must do this with everybody rule. That would be stupid. I'm asking people to think about what is the advice we're giving, and how about we use our professional minds to clinically reason what would be actually suitable for somebody.
I love that, more individualized approach is what you're saying, and for people who are just like, "Well, I wasn't given that, I wasn't even given the opportunity." For the women that you've trained, my question really is, at what point does their, you know, base activity, whether they were a Pilates instructor, which I've heard you mention before, whether they were a runner or mountain biker, how should they be treated? Is that day one, or is it a certain time frame, after their C-section or after their birth or whatever it is, that we're starting to actually apply these principles and treat them individually?
Well, it's in the word principles, right? They're principles, they're not protocols. So at what time do we apply the principles? We always apply the principles at all times, because the principles are pretty simple, which is person-centered care, honor the individual, do no harm, and then just think about what their goals are. We want to get them moving as soon as possible. We know that this is a good thing. And if it's not appropriate for them, then yeah, we need to care for these people. And I'm going to argue that it's much harder work to individualize care. It's much easier to go in with a sheet of paper, tell people this is how it's done, and you move on to the next person. So I am asking people to use their brains, and this might be harder work to individualize care, but I'm going to argue that it's much more satisfying, and the person's going to feel a lot more cared for if it feels like they've been individually catered to. So yeah, I don't remember what your question was. It's early in the morning here, and I literally got off a flight yesterday from India. So I hope I answered your question. Apply the
Yeah.
principles at all times.
Most people, yeah, and they don't realize you're on a call from Sydney, Australia, 7:30 in the morning or so, where you are, I believe. Is that right?
That's
And,
correct.
I just spoke with a woman today who's just really inspired this talk. She's 6 months post C-section. I was told that she had to get a C-section, was really dismayed at it. And, she's pretty irate. Like, why wasn't I told anything? I have this massive amount of weight now right around my C-section scar. There wasn't anything before. She called it a fupa. But, she's very active, very strong, back in Pilates, but she just feels pretty defeated. And I wanted to share just even part of her story. And a question for you is, in terms of just her standpoint, she's looking at more of this as being aesthetic, also just in terms of her function. And she's frustrated that she wasn't told much about her diastasis recti, which is about three, nearly four fingers of a separation. And really my question for you is in that case, was she failed in that way?
I'm going to be controversial. and say, I don't think so, but you've given me so little information, right? So what I really want to know is, why did she have the cesarean section? Because there's a lot of injustice experience coming through just a little bit that you've given me. It sounds like she feels like something isn't right. Like, why did she have this cesarean? She was told to. There may have been very good reasons. We have a lot of women and babies alive today because of cesarean sections. And when you consider that the USA and Australia are both number one and two of the most litigious nations on earth, I also understand why people will just do less risky things, in inverted commas. I don't agree with it, but just to cover their own ass, right? Like, imagine being a doctor and being told in a breach presentation, whatever it is, right? Like, whatever's going to scare a doctor, that, yeah, no, I want to try vaginally. And the doctor's just thinking of all the things that could go wrong, could lose a mother, could lose a baby. And you can understand why they make the decisions they do. Now, do they communicate well? Probably not. It sounds like this person that you spoke to um, hasn't had a good communication perhaps with their providers if they feel like this 6 months down the track. That's number one. Number two, diastasis. You know, diastasis has been around since people were getting pregnant and giving birth. So I think in our social media, thanks to Instagram, especially from 2016, it started getting a lot worse, where people's highlight reels get compared to our behind the scenes reels. Yeah. Does it make it less important? No, it doesn't make it less important, but it's not a life threatening condition if you don't count the mental toll, right? The mental health toll. Aesthetics are very important to people, and people will tell me, I don't care about the aesthetics, I care about the function. It's like, okay, if I can get you doing absolutely everything you could ever want to, everything you could ever want to, and more, better than before you got pregnant for the first time, I could have you stronger, faster, jumping higher, all the rest of it. And there was a way to do it where one looked better than the other. Which way would you choose? And they would say, well, the one that looks better, of course, because aesthetics do matter. Maybe they're not the first priority, but they do matter. So I think it's very valid to say that it's important. That's number one. And number two, I don't judge people for that. Number three is, whilst acknowledging all of that, we've somehow conflated aesthetics are important to people to making it medically important. And so the way that I described it, I've described it for years, decades. If somebody wanted to have their diastasis repaired, it's an abdominoplasty, and they turned up to a party on the weekend and they said, yeah, on Monday I'm going in for this operation. Look, the doctors have told me I have to have this, otherwise I'm going to have low back pain. I'm going to have pelvic organ prolapse. I'm going to have leaking if I don't have this surgery. Yeah, so I have to go get a tummy tuck. Like, people would be like, oh my God, it's so terrible. Whatever we can do to help you, let us know. Right? This is my this is my perception of what is out there. And then if somebody turns up on the weekend to a party, to an average party, okay, not one where plastic surgery is done all the time by the participants. And they said, oh, on Monday, I'm going in for surgery because I really don't like how I look since I've had the babies. Like, I think there's a silent fear of judgment. I think you're going to be judged by some people, and you don't know who those people are usually. Whereas if you're doing it for a medically important reason, like, oh, I don't want to get back pain, I don't want to get pelvic organ prolapse, I don't want to get these pelvic health concerns, even though the evidence does not support those statements, then I think it's easier to choose the one where you're going to get less judgment for. And this is where health providers take the brunt of the blame, in inverted commas, because then it's like, well, the doctor said I have to. Like, what am I supposed to do? And What if it's actually the fact that you don't like how you look? That means that you brace your tummy all the time because somebody says that you have to use transversus. Like literally the last 2 weekends, I've been blowing people's minds. Every time I do the diastasis course, I blow people's minds because I show them just how gentle it is to isolate transversus, just how powerful their internal obliques are. And, you get to watch on the ultrasound how far rectus gets stretched across the tummy because they've been told not to use their rectus. And so you get to watch this thing stretch out. It's, we say we're doing certain things, we're not. And that's the reason why I have the ultrasound. So again, a rambling response. I hope I answered whatever question it was.
You did mention really kind of a couple things in there. One of them you didn't mention that I do want to ask about is diaphragmatic breathing. In one interview that you did, you said it sounds important, but it's really not doing anything. And that kind of leads me into even the transverse comment that you just made. It's like exercises like that, from what I understand, if I'm, just a regular person hearing this who's been told, well, you got to contract your deeper core muscles before you can do these big movements. So if I've been told I have a diastasis recti, which is, anything that's anyone after a C-section, you might as well you've had your muscles separated, for the surgery. But if I have now this diastasis recti where my muscles, there's still some distance between them. And I want to say, at the linea alba, if you've had, the vertical incision, as you mentioned before. So if I'm a regular person who's had that and I still have a bit of a separation, and I've been told I need to do deep core muscle activation, your transverse abdominis, maybe exercises, and then diaphragmatic breathing. In other interviews that you've given, you've really dispelled the myths about those two. Will you share that with us?
Remember what I said, it depends on how heated I get. The bottom line is that all breathing, unless you have a phrenic nerve injury, is going to involve the diaphragm. So to call it diaphragmatic breathing is like saying, we've got some wet rain today. Like it just sounds stupid to me. Wet rain, look at that. It's like, what, do you think you're breathing without your diaphragm? Like your diaphragm's working, right? That's number one. Number two is if you're breathing, you're going to generate pressure and muscle contraction. Anytime you generate a muscle contraction in your trunk, you will increase the pressure and your muscles will respond. So again, when I use the ultrasound and you just sit there and you watch transversus and you ask the person not to do anything, and once they finally relax, you'll begin to see that breathing induces muscle activation in the transversus because it's responding all the time to different things. So I can go into all the technical details as to why I think it does that. But what if we just reconsider why? Because people will say, but Anthony, I do these things and people get better. And I agree. I agree. They get better. Number one, what if the reason why they get better is different? And number two, does it matter if what you're teaching them is not actually what's happening? So with the breathing and the transversus exercises, and you can't load before you can do them right, whatever that means. What if having them lie around for however many weeks it is in their busy life? What if that's exactly what they need? They need to lie down in your class and do nothing for an hour except breathing, these gentle contractions, some bent knee slides, some leg slides, some bent knee fallout, some arm drops, some really gentle movements, because the rest of their life for that day is up and about, walking around, generating far more tension on their diastasis and generating far more muscle activation than your exercise class will. What if that's the thing that gets people better? What if literally, again, provider provided excuse to go have 1.5 hours off is actually the therapy they need? Now, it's pretty hard to sell that. Come to my class where you get to do sweet F all and that's going to be restorative for you. Like, it's hard to sell somebody on that, right? But, oh, you got to appeal to the people that want to get above 80%, then you've got to master these things. And until I say that you can master it, you're not allowed to move on. Like, that's an easier sell, right? So, what if it works? But what if you're just helping people to just break the cycle in their life that perpetuates the things that affect them?
Your quote, and this is really from research that you pulled from, Antony, was that by the end of a year postpartum,
Mm,
2/3 of
mhm.
women actually show signs and symptoms of no diastasis rectus
Correct.
abdominis. And so I think what you implied even in that comment was people get better. They get better with or without you.
Yep.
But the industry is huge when it sells the treatments for diastasis recti. Industry is a huge industry, to sell treatments and cures.
Yeah. And, what if by the end of your 6-week, 12-week program, they show improvement just because they were going to improve already? Like, how do you compare what hasn't happened? Like, you can't. It's an impossible research study, right? It's like this person was going to get better anyway. And it's like, well, how do you prove that? Because there was an intervention done. It's not like a crossover study where you can say, okay, now don't do anything and let's see what happens. Because it's like, well, that time has passed. So, also people don't like that the same study, was it the same study? It was by the same group, showed nearly a 4-time increase in pelvic organ prolapse incidents in those without a diastasis than those with a diastasis, because it doesn't match their model. People think you're going to have pelvic organ prolapse if you have diastasis, and that's going to be because of the Spitznagel study, which was there. But what if, which was a retrospective observational study, right? In a biased, it's people presenting to a center. So what if the diastasis in nature's special way allows people to offset pressure down onto a perineum that's just given birth, onto the pelvic organ, instead of just being like your uterus. I don't have to tell you, gets massive and swollen and engorged with blood and then has to shrink over a number of days and weeks. What if during that time, the diastasis helps to mitigate that? What if we know from certain studies that every week postpartum, you increase how much intra-abdominal pressure you can generate? We also know from certain studies that every week postpartum, your diastasis changes size and it decreases in size. So, what if diastasis is just helping you mitigate the pressure so that you don't get pelvic health issues, and it's actually a positive adaptation? And like most adaptations, it helps lots of people. I think 2/3 is good. I think that's more than half the population. 2/3 will have an improvement or no diastasis. And, and for some people, it doesn't quite get back there. So, yeah, what if we just make it bigger than it needs to be? What if diastasis is the antenatal postnatal world's wedding industry? Like, you know, I resisted developing a course for the longest time, but I just couldn't stand having stuff out there that was just erroneous. So I built my own. I have a course to sell, blah, blah, blah. Do with it what you will. I just tell the truth on there.
Why did you resist for so long? You gave a little bit of your background, which I really was quite pleased to read that you had worked in antepartum, as what we call it here in the US, antepartum clinics. You had worked on the maternity ward, so you had worked in the hospital with women after birth. You
Mm.
obviously you worked with those individuals after they gave birth in outpatient clinics. Why is it? Why did you resist so long in creating a course when you knew the standard teaching was to close the gap. I mean, it's everywhere. Closing the gap in diastasis recti is the industry.
Yeah. So here's a funny thing, right? Number one, closing the gap. Well, what's the opposite? Like, the opposite is tension across the gap. So I, for aesthetic reasons, I think closing the gap is going to be number one, it's an easier sell. But I don't know how you make that claim with any sort of evidence backing apart from personal experience, the lowest form of evidence. Number one. Number two, like tension across the gap. Transversus pulls the diastasis apart, like it pulls it apart. But we're supposed to have tension on the linea alba. Okay. So why are we afraid of doming? Why is doming so bad? Because doming is just pressure taking up tension in the linea alba. Now you have tension in the linea alba, but you don't like that you have tension in the linea alba? I don't understand. So to me, closing the gap, I don't think closing the gap is that important. I think having a strong rectus, in addition to strong other muscles, is important because having your rectus, two columns from which you can have your other three muscles, external oblique, internal oblique, and transversus, be able to pull and provide that dynamic myofascial force and have your rectus be able to twist and move dynamically. I think that's far more important than having tension across the linea alba. It doesn't make sense to me. Anyway, I can go on about that too if you want.
I do. I remember kind of coming across a post on the diastasis or diastasis project, and you were talking about hard doming and soft doming. And if I were to have, someone just understand that from what you were talking about, it's not important to have much tension in the linea alba. Couldn't that lead to the hard doming that we don't want? That would be more of a problematic is to have the hard doming. Is my understanding on that right?
So the hard doming is not what I advocate. I'm saying that we're closer to tearing. But let me just try answer. So to me, if you see doming, whatever that is to people, if you press in the midline and it's lax, you can push it in. Think of a hernia that's reducible, okay? Diastasis is not a hernia, just for anybody listening. If you can push tissue in the middle where the diastasis is, and your rectus muscles are harder than the soft tissue in between. And I mean, so that you can feel the edge of the rectus, right? On the medial edges of the rectus. Then how is it that we're making this tissue worse? That's kind of like saying sitting on a chair is going to lengthen my hamstring muscles when I have my knees at 90 degrees and my hips at 90 degrees. It's going to lengthen my hamstring muscles. Like you'd think that I was stupid if I said that. And yet nobody's checking for the linea alba like this is before, right? I'm like, why are you worried about doming? And they're like, oh, it's going to make it worse. And it's like, how? Like if I've got my shirt here, okay, and I wanted to tear my shirt, you're telling me that if I keep the cloth not under tension, where it's soft, where I can move this cloth around, that now I'm at risk of tearing this shirt. What's going to have to happen to tear the shirt? I'm going to have to pull apart here such that it gets hard here and it has to pull apart like this. Guess which muscles pull apart? Transversus abdominis, internal oblique, and external oblique. Guess which muscles take tension off the linea alba? Rectus abdominis. This is indisputable. This is in the research. I don't understand why rectus gets such a bad rap and why we're scared of soft doming. Does not make sense to me whatsoever. Nobody can challenge this from a scientific point of view that I've been able to have a discussion with. Like, I'm happy for it. If somebody wants to go me on this, that's an Australian way of saying, if you want to challenge me on this, please, I am up for it because I'm happy to be wrong. Just show me science and evidence. And like, if we don't have the research evidence, then at least let's have scientific plausibility because we know from materials science that on a stress strain curve, you got to get to the plastic zone before we get permanent deformation. The plastic zone requires a lot of tension to get there. So whilst there's not a lot of tension in the linea alba, I don't understand what we're concerned with.
Do you think that transverse abdominis exercises increase the incidence of hard doming, of that tension in the linea alba that can actually lead to rupture?
I'm going to go with no because I'm very literal, Rebecca. I'm very literal. Transversus abdominis exercises, I don't think generate enough tension to do that. However, there are very few people that can truly isolate their transversus abdominis on ultrasound. Most of the time, they're using their internal obliques. Internal obliques can tension hard enough. You combine that with no rectus, like you try to minimize how much rectus you're using, and then you've got to jack up the intra-abdominal pressure. Like the number of people that I get to hard doming is precious few. It's very difficult to get somebody to hard doming. It's doable. In fact, I would argue that, those people that report to you that in the morning their belly is soft and by the end of the day it's hard. I would argue that just being upright puts much more pressure on your diastasis than doing transversus exercises, even if you're using your internal obliques. So no, I don't. But I do think that doing your transversus exercises in inverted commas, which will be your internal oblique exercises for most people, I do think that that's enough to maintain a diastasis. Because when in the people that I've seen, so I have not seen everybody in the world. I see a very minuscule percentage of the world. When I ask them to stop doing their transversus exercises, start doing regular exercises, stop with their diaphragmatic breathing, especially the belly breathing. Like, what do you think's going to happen when you breathe into your belly and you stretch out your belly? It's going to stretch out your diastasis. Anyway, when I get them to stop doing all of that in such a disciplined way, they get better. When I introduce 3D motion, they get better. Why? Because it's much more normal to move in 3D. Like who sits there and thinks about their transversus all day? That's dysfunctional. We got to stop making people dysfunctional. Let's not do that. It's not normal. Like, let's
You
just have people
mentioned
move.
you did. You mentioned this actually in another interview about not focusing on the exercise or not focusing on the muscle that you're exercising.
Yeah, dumb. Like, touch your nose is my favorite one, right? I've been doing this one for decades. Touch your nose. Touch your nose, Rebecca. Go with me here. Did you think about every muscle that you needed to do this?
No, I didn't.
No. But what's the primary elbow flexor?
Biceps brachii.
Okay, I want you to think about your biceps brachii for me. Activate your biceps brachii. 3 out of 10, okay? 3 out of 10 activation. Now touch your nose. Think about your biceps when you touch your nose. Now touch your nose. Which felt normal? The first way or the second way?
The first one for sure.
Yeah. So why would I take somebody who is normal and make them dysfunctional? I don't understand. If I was cynical, I would say that we were trying to suppress people for monetary gain. But I know that health is not the best way to make money. So I know that we're just trying to do the best for people. And I'm asking us, like, to pass PT school, right? You got to be smart. You got to be some degree of smart. Like, we had to get good grades. So let's just use the brains that I know we have and question the theories and the things presented to us as fact. Why can't we have inquiring minds? Why can't we question authority? I'm Australian. We've got a long tradition of questioning authority. But around the world, that's not always the case. Is it because we're a convict nation? Maybe, but I embrace it, and I'm contrarian. So it just naturally goes with my personality. Anyway,
Why did you feel that you had to almost break this cycle? Because I was taught right around the time where I started to hear you speak, I was doing a residency. So I was taught about muscle isolation. I was taught about diaphragmatic breathing. I was taught about muscle isolation in different positions from supine to sideline to being on all fours, just trying to isolate, the transverse abdominis, the pelvic floor, try to do them together, all of it. That was my training.
yeah.
And so what broke you finally to just say, that I have to I have to put my 2 cents in?
I used to be very much the way that you were taught. I used to be like that. I'm not going to lie. I was very much like that because it was the way that I was taught. And it was the most complex ways. It's the most complex of ways. And I'll even mention it because I know that Diane Lee knows this because I've told her this. Diane Lee and the work that she's done has been fantastic. I think she's really tried to explain what is going on in the body and what she's observed clinically. When she was working with LJ Lee, the thorax stuff, a lot of that stuff I find helpful and I use every day in my clinic. And it was the most complex of things, right? Like it's pretty complicated if you go down the rabbit hole. And I was pretty good at it, to be honest. And I still couldn't help everybody. I was I was not helping somebody, and then they were seeing somebody else, like a trainer, a Pilates instructor, another physio, a chiro, an osteo, and they were getting better with those people and not with me. And I was doing the right thing. I'm pretty confident that I was applying all the right things properly, and I realized that something was wrong. Like either I'm not good at what I do, or the model was not complete in the way that I was learning and applying it. And so um, part of the journey was that I'd learnt muscle energy, and it was from learning muscle energy technique that I learnt about Diane Lee. So I was doing muscle energy technique, and I was pretty good at muscle energy technique. I probably couldn't do it now, but 20 years ago I could. Where I could carry on a conversation about what was happening on the weekend and do all the positional testing, apply all the right things, get you better, get you out the door, write my notes up, and not have to think about it. Right. I was pretty good at it. And anyway, after this one person had come in, I was writing up my notes, I was writing up the positional diagnoses and the treatment that I gave. And I realized that I had applied a forward sacral torsion technique on somebody who had a backward sacral torsion in the parlance of muscle energy technique. And I crapped myself because I was told that if you do that, like you're going to mess somebody up. They're not going to be able to walk properly, like whatever. And I'm like, they got up and they were better. And all the positional testing was better. And I was like, huh. And so then the next person who came in that needed that type of technique, I just did the opposite. For an upslip, I would treat them like a downslip. They still got better, you know. For an anterior rotation, I did a posterior rotation technique. They still got better. I'm like, what is going on here? And anyway, around that time, I also started learning more about the science of pain, and I'd helped somebody. She was booked in for knee surgery. She couldn't bend a knee, and she was on one of my courses, and I found it was a thoracic ring issue. I taught her how to self-correct her thoracic ring in the parlance of that. Yeah, she got better. She could squat, and then 2 weeks later, she was pain-free. Like, she could squat, but she couldn't even squat before, right? She couldn't sit down on anything than a regular chair. She's pretty short. So anything more than 90 degrees knee bend, it was painful. She was going in for surgery. Saved her from surgery. Anyway, I posted this somewhere, and Greg Lehman had commented on something, and it was the end of 2013, I think it was, and we just went at it. like backwards and forwards. Like it was pretty intense. It was fun. I was being challenged. Greg Lehman, he knows this. He doesn't remember it as much as I do because it was a life changing moment for me, right? For him, it's just another argument on the internet. So we're going back and forwards on this stuff. And I think my memory is I said something along the lines of, so are you saying that all these people that I've helped with thoracic ring theory, I didn't help? He said, no, I didn't say that at all. And it's true. He hadn't said that, but I took it personally. That's when I realized that having your identity wrapped up in what you do makes you vulnerable to feeling personally attacked when people aren't personally attacking you. He was talking about like all the mechanisms that I said that was happening. He was talking about how there's too much in the way of attenuation of the tissues as to why changing the thoracic ring mechanically wasn't going to be the reason why her knee pain went away, stuff like that. I don't think we ever came to a reason why she got better, but she got better, right? He never said that she didn't get better. It's just like it's for another reason. And thus began a 3-year journey pretty much of I'd already started that journey. So it's another 2 years of me really trying to reframe everything that I'd learned and trying to change the way that I thought about what I did and how I did it and why I did it. And so I didn't become a Bluetooth physio, hands free, no manual therapy. I still use manual therapy, mobilizations, manipulations. I still use muscle energy techniques sometimes, you know, dry needling occasionally. I do these things for different reasons now, right? I do them for different reasons. And I think about the mechanisms as being something different. I don't know what they are for lots of things, but I do trust that the changes occur. I just don't give the same old story that I've given before. And I think that's much more honest, morally, ethically, intellectually. And, do I think we all need to be like that? Of course I do. And do I think everybody will? Of course I don't. But I think that it makes a difference. And for people that need a scripted protocol, and I've got patients like this, I will give them that because that's what they ask me for. I say, you've got a couple of ways here. Here are the principles. Go off and make your own program. And I've got people like, wow, so much freedom. I love this. And I've got other people that are like, oh my God, I don't know what to do. I need you to tell me. And I say, that's okay. I can tell you. Start with these. And then we go from there. And I've got people that want to come in regularly for a grease and oil because they like that. They like some mobilization and manipulations. They know that it's not going to prevent anything, but they like how it feels. They like the therapy. They like the chat. And they like to know that they're going okay and they're willing to spend the money on it because I ask them, you okay with this? You don't have to. And they go, no, I like to. Okay, that's fine. This is what works best for them. Okay. We've tried all these other things. This is what works best for them. Okay. I feel like I can ethically sleep at night because I'm not selling them on a lie, you know? And so it doesn't make me, as Adam Meekins might say, it doesn't make me a physio whore because I'm just giving people what they want. It makes me clinically reason through the whole of person-centered care. I'm not doing it just because they asked me to. I'm doing it because I've considered from a broad biopsychosocial perspective as to what's helpful for them right now. And I check in with them and make sure that they know that they can change their mind. So I've got regulars that I see, and I've got people that come in when they need me, and I've got people I see on Zoom whenever they need me. Like, and that's normal. I think that's normal because everybody's a bit different. I don't know where I was going. I hope I'm answering your questions.
Anthony, you teach a course, diastasis done differently, not just to physios, is that right? You teach fitness professionals, you're teaching personal trainers, you're teaching anyone who has a touch point with someone who is dealing with an abdominal separation. And That course, you've opened it up to such a broad spectrum of people. Why should people who are hearing this, trainers, or even the women with the conditions that have just, in some way or another, probably been lied to about what this means? Why should they take this particular course when there's so many courses? There's so much noise out there about diastasis recti. What would they get?
Yeah. Well, first of all, I just want to address they've been lied to. I don't think people are deliberately lying to them. Like, if there is an absolute truth, I'm not sure our current evidence based system allows for it because of inductive reasoning. So there's always going to be doubt, right? And providers of education are simply just trying to do their best. I don't think there's many people in the space that are just out to get people's money. So I wouldn't say they've been lied to. They might feel lied to once they know a little bit more information. But I would say that the information they've been taught is older or outdated. Why should they do the course? Because they're going to get anatomy, they're going to get principles, they're going to get exercises, they're going to get the assessment process. They're going to see 3 live cases, like 3 recorded cases, like that were recorded live with updates and a written case study. They're going to get stuff that's going to be helpful for them. There's an extensive exercise library. I've put my exercise protocol in there with suggested exercise examples for different phases. It is thoughtful, most thoughtful of pregnancy postpartum, and that's because for children with diastasis, I think children with diastasis is pretty simple. Number 1, you don't make a big deal of it. Number 2, you make sure the child is doing 3D motion, right? So make sure they're playing some sort of field, court sport. It could even just be tag. Like, as long as they're bending, twisting, moving, this is going to be helpful for them. And multi-directional, right? Multi-directional sport. And most of them are going to be just fine. My son for 15 years had a diastasis. I noticed it when he was very young, when he was a baby. I didn't even tell my wife because it's not a big deal, right? But I didn't want it to become a big deal. So I didn't even tell her about it. I just kept an eye on it. And every summer, we have a pool. Every summer, no, it's still there. And then one summer, it wasn't there. I said, "Hey, can you just jump up on the side of the pool here and let me feel?" And he goes, "What are you looking for?" I said, "Oh, you don't have a diastasis anymore." He goes, "What do you mean?" I said, "Well, you used to have this split here, and I used to be able to see it, and now I can't see it anymore." He goes, "Was it bad?" And he's like, "No, otherwise I would have done something about it." Yeah, but there are people out there that are like, for your child's diastasis, you've got to do these things. And it's like, really? You could just do the simple thing. Make sure they do 3D sport because kids will be kids. Let them be kids, right? Anyway, um, and for men, like guys will get it. I have a diastasis, 4 fingers wide near the umbilicus. If you ever see me in person, you'll see that I've got an umbilical hernia. It's there. I've imaged it and I'm not particularly concerned by it. And it's because I have visceral fat. I have too much visceral fat. I can go into my whole personal medical history. Unnecessary. Bottom line, it happens. Get stronger. Like, it was good. I was on a course. There were fitness professionals and physios there. And I was demonstrating how to do a hollow rock because I can. And they couldn't, which is pretty funny, right? I could hold sustained spinal flexion and hold my position with long levers, and they couldn't. But I'm this fat dude that looks unfit that shouldn't be able to do this, but I can, you know? So I think it's good for all professions. I think the nerdy stuff will suit the health professionals because we tend to be nerds, right? And if I was going to broad stroke it, a lot of fitness professionals that became fitness professionals after school, it's not that they're dumb. They just didn't do well at the nerdy stuff. So I've met a lot of smart fitness professionals that when you just spend time with them, you can learn so much from them. I've learned more exercise stuff from fitness professionals than I ever have from university educated professionals. So I think it appeals across the range. And I go into the anatomy. Somebody on the course said, I've done other courses, but like your anatomy was like the one. Like that really went into it well. And I talk about the hard doming, soft doming. I talk about Valsalva versus bearing down, straining. I talk about, the couple of case studies that I had who had intravaginal pressure sensors in, where you could see that on a long exhale, they had more pressure, and on a long inhale, they had like negative pressure. Now, for some reason, people keep telling me that when you breathe in, especially diaphragmatic breathing, you increase intra-abdominal pressure. And it's like, if you breathe in, how is your pelvic floor relaxing? Right? Because anytime you do anything that increases pressure, I will guarantee that your deep muscles will contract slightly in response to an increased pressure, because that's literally in the definition of what transversus does and what the pelvic floor does. It manages pressure. How does it manage pressure? When the pressure is induced, it contracts to help control it. So when you breathe in and you're relaxing your pelvic floor, what if you're teaching people to relax their pelvic floor during an increased intra-abdominal pressure? Because, the pelvic organs might be descending or whatever. What if we also teach them to do a breath in and a pelvic floor contraction? Like, in fact, many people do this already. Because what is the knack? You're a pelvic health PT, is that right, Rebecca?
That's right, yeah. What is the
Right.
knack? So
What
it's a
is the knack?
contraction. It's a contraction of the pelvic floor muscles before an anticipated increase in an intra-abdominal pressure, like a cough, a sneeze,
Right,
maybe laughing. So you're teaching people to control or contract their muscles.
right. What's the thing that you immediately do before you sneeze?
What, like
Like
in
simulate
normally?
sneezing. No, simulate
Shoot.
sneezing, right? So the first thing you did was you went, chew. It's a
Uh-huh.
breath in.
It's a breath in. You're absolutely right. Yeah,
And when you do the breath in, guess when you need the knack?
right then.
On the breath in. Because you can't wait till you're halfway through your sneeze on an exhale before now you put your pelvic floor contraction into place. Because it's not exhale and contract, it's exhale a bit and then contract. Like, do you know what I mean? Like this whole finicky, we got to learn how to coordinate it properly business. No, then contract, support, have it there. And the research shown by, I can never say her name right, Yun Jungiger, 2018, that submaximal pelvic floor contraction for the neck was better than maximal pelvic floor contraction for bladder neck support. Why? My theory, I can't remember what was said in the paper, but my theory has always been that if you maximally contract anything, you make yourself rigid. You make yourself rigid, you're going to have trouble adapting to changes in pressure and force. So with a submax contraction in place, when you go to massively increase that pressure, and it is a massive increase, cough and sneeze is one of the highest intra-abdominal pressures that you can have. So when you have that sudden increase in pressure, you're going to have to respond. If you've already maximally contracted, you can't respond anymore. So you're just hoping and praying that that's enough. Whereas, what if, and this is a big what if, okay, there's no evidence to support it, but I've been around long enough to have heard lots of stories. After you've given birth vaginally, you get the perineal distension. And I've been told, I don't do internals, okay, but I've been told that a perineum that's given birth vaginally feels and sits differently to those that haven't given birth vaginally. What if there's been a stretch of some of the tissue and the fascia? And, you know, I have to go look it up, but a long time ago, I think I read research that showed that people with incontinence, especially on a sneeze or a cough, they don't have a delay in pelvic floor contraction. It's just that it doesn't get to support in time, right? And so, what if they're just starting from a lengthened position, and by the time the pressure's there, they're still in a mechanically disadvantageous position. What if that submax contraction restores that length tension relationship that allows that quick contraction and support? What if that's the reason why it's helpful? Like, why can't we think of many reasons why something is helpful? Because the knack is helpful. But I've always taught a submax because the max, I just ask them, all right, I want you to squeeze your pelvic floor for me. Do the max contraction because that's what I was taught, right? Do the max contraction, cough, and they're like, oh, it doesn't feel good. All right, just give me half. And they do half and they go, oh, that feels much better. I was like, well, just do that. Like it feels better. Like just do that. Right. And that's how the submax for me came about. That's over 20 years ago. Right. And then you find out in the research it's there. When I saw it, I was cheering. I was so happy because I remember having arguments with a prominent pelvic health physio about this, and I was being put down for not knowing. And then it was like,
And to make people who sign up for your course, which I'm really excited about, you've been really all over the world teaching diastasis done differently, and it's really in conjunction with the female athlete course that you teach. You actually encourage people to take those together if they can. Do
yep.
you hope that the way that your approach to children with diastasis recti, rectus abdominis, to men who have the condition, do you hope that therapists, fitness trainers will leave with the same information that we would use with those populations? 3D fitness training, no itty bitty exercises, which I've heard you say. We're under training people way too much. We're having them do all these isolated contractions in various positions. We're starting with diaphragmatic breathing, which makes no sense. Are you hoping that with this course, people will really, really approach diastasis rectus abdominis way differently than we have been taught?
Yes, of course. Of course, I'm hoping for that. With the diaphragmatic breathing, by the way, I don't have a problem with what people are teaching. It's just that way is not the only diaphragmatic breathing, and the way they're already breathing is diaphragmatic breathing. It's just looking different, a different pattern. So, what we're doing is we're simply doing something different. Part of that 3 year journey that I spoke about earlier was about simplifying things. And so I went from peak complexity to peak simplicity. And the peak simplicity that I've come to is do something different. That's ultimately what we do. You see somebody breathe in a chest breathing way and you teach them to breathe in a belly breathing way. You're just changing the way that they're doing it so that they have two different ways. And, you know, we we talk all the time about biopsychosocial. We talk all the time about how damaging words are, and yet we use judgmental words all the time. And my hope is that people will also see that the language changes. That, you can say good to everything that the person does. Like the person does something and it's worse, and I say good. And they go, how is that good? It's like, good. Now we know what makes you worse. Like, why can't we use words like that, right? Rather than they get so much of the negative out there already because fear sells. Why can't we be a positive force for good? And so that's what the course also does, hopefully. Hopefully, if you want to change somebody's breathing, don't say you're breathing wrong. It's like, well, they lasted this long. They can pay for your services. They're adults. So don't tell them they're breathing wrong. Tell them you're so good at breathing this way that you don't have to practice this way. But you seem to have trouble breathing this way. And we know that variability is really, really important, right? So have a variety of ways to breathe. I want you to practice this way as well because you're already good at one way. Let's also get you better at this way. And when you get better at this way, I'll teach you some other ways to breathe as well if you need to. But I suspect that once you realize there's more than one way to breathe, you'll just breathe in many different ways. And that's normal because variability and adaptability is normal. We got to think of people as scar. We scar them with our words, at least make it a good scar, strong, capable, adaptable, resilient. And that's how we should be leaving people. If you don't think about your clients and your patients that way, they're going to tell that you think that they're weak and they're incapable, that they're doomed to failure and they're fragile. Like, imagine that, going to see somebody and feeling like you're fragile. Like, is that really how we want people to view themselves? Especially because of us? Hopefully not, right? So, anyway, there's a lot that goes into it. I love metacognition. I'll be starting a new podcast on that soon. Just thinking about your thinking. It's important. It's an underrated skill. It's one that I'm not an expert at for sure. Why else start a podcast except to learn from other people who do know this stuff? So,
I completely agree. Anthony, where can people find your course? Is it always going to be updated on your website if people wanna take it here in the US?
yeah,
To kind of request or be a host? Like, how can we take your course here on this side of the world?
the website is mypteducation.com is where all my education stuff is, or antonylo.com will, if you want mentoring, if you want a case conference where, I can do like a consultation with your client. And so they pay for the consult and you get the continuing education and working together with me. That's a handy way of doing things. And I
That
always,
I mean,
I
that's
always
virtual.
uphold, I always uphold the provider, right? Like that's important. I never throw anybody under the bus.
Wait, Anthony, can you explain that again? So you're saying that you'll do a virtual consult with a client, with their physio,
Therapist, yeah,
with their therapist on the call, and you'll always, uphold the therapist in terms of, like, what they've been doing. If they've been doing diaphragmatic breathing for I just
100%.
for
100%.
something like that, you'll then change the direction of maybe their plan of care.
Yeah. Yeah. Like, I mean, usually when I get those calls, it's because the therapist is at a crossroads and they don't know what to do, or they haven't been able to progress and they don't understand why. Like, yeah. And so they can be on the call if their schedule allows, or if if the patient wants to give them access to the recording, they get the recording. And now that I use an AI note taker, they get the notes as well. So, just like you'd send for a consultant review, that's what it's like, you know? So
Do you
yeah,
feel
you
like
can do.
that with therapists who don't feel like virtual care is effective, what's your response to that? Trying to do a virtual care consult with someone who has diastasis recti.
Wow, my goodness. Diastasis is easy, right? Like you really don't need much hands-on for that. And whatever hands-on you need, the patient can do themselves. It's going to be hard if you're doing stuff that requires, I would never do anything internal. Even when I get them to do an external palpation on the perineum, I tell them to put the camera where I cannot see them. Like, I don't want any hint of anything private going on the internet. So you'd be surprised how much can be solved just by listening to the person and sifting through all the things that have been done. You know, it's just a different way of working, from what I understand, especially the American way. It's just a different way of working, a different way of thinking about things, a different way of running a consult. Yeah, it's particularly effective. I've got lots of consults done on many different many different things. There was one person I saw, her trainer referred her to me because of persistent pain. This woman was getting 20 weeks of internal pelvic floor releases. It didn't help. Then she had surgery, which she was told would solve the problem. Of course, it didn't. And then she had another 6 months of pelvic floor releases, which didn't help. And I was able to help within 3 sessions. And it turned out she had dyspareunia since her early 20s. Nobody had asked her about this. She had central sensitization. And so the cesarean scar, which is what I was dealing with, that was just an extension of her dyspareunia and her sensitivity to touch and all sorts of stuff. Like there was a 20-year history that nobody had dealt with. So once she understood that, and once the graded exposure started with her husband, who was there, things got a lot better. Don't know how she is now. I don't go follow up people, right? They
And that
they
was
follow
all
up with
done
me if they want.
virtually, Anthony? That was done
Yeah,
virtually.
virtually. Yeah. Yeah, 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 virtually.
Antony, your courses, they've gotten my attention. I wanna take your courses. Will I have to travel internationally? I'll stay on your website, but I understand that you also offer them already recorded, so I can even do the diastasis done differently, self-paced if I wanted to.
Yep,
But if I see
American
you
CEUs as well. APTA approved,
mhm.
American CEUs for most states, 40 odd states. So yeah, it's doable. And hopefully I'll be coming back to America with it. Where are you based, Rebecca?
Colorado.
Ooh, I was in Colorado 2020.
Yeah,
It was end of February, start of March 2020, right before COVID.
absolutely. You'll have to come back to Denver.
I would love to come back to Denver. It was great.
Absolutely. Well, I would love to see that happen, Antony. I can't thank you enough. This conversation for me started out very personally, but I think a lot of our passion in this field does, quite honestly.
Yeah, and again, if I keep having to repeat it, right? If you've been teaching people things that I disagree with, it's not because you're a bad person. I actually hold the educators responsible for not teaching the accurate things, right? And so you've been doing the best you can because you were doing the things that you were taught and you see that it worked. I'm not asking people to stop doing what they do. I'm asking people to think about changing the narrative around why what they do works. Because I believe as professionals, we have an ethical responsibility to teach people the truth. And when we find out that something is not the truth, we can either double down or we can change. And change is the hardest thing to do. A lot of people have a lot of meaning around what it, like if I change my mind, like people are going to think that I'm wishy-washy or I don't know what I'm doing. It's like I would rather I would rather see somebody who's willing to change their mind than somebody who is obstinate in the way that they're doing things, right? Like how many times have we laughed at surgeons and specialists for not changing with the times, and yet here we are also not changing with the times, right? So I don't want to be a hypocriticizer. I hold educators responsible. So for the educators listening, I think, it's worth thinking about what you're teaching and why, because, earlier you asked about why were we doing all these itty bitty exercises. I actually pulled out my phone if you've got the time for this, but I encourage people to pull out this stopwatch app on the phone. Do you have your phone there?
Oh yeah, I
You
got it.
got your
Yeah,
stopwatch app? All right.
yeah.
What I want you to do is to press the start stop button as fast as you can.
Okay. Starting when?
So whenever I want you to just press it. Watch this, Rebecca. Ready?
Uh-huh.
So that's 0.13. I want you to get the lowest number that you can. Oh, 0.08 for me.
Wow. Man, that was bad. Okay. Yeah, that was 14. Let me stop.
Yeah.
And
Yeah. Get faster.
again, point 13, point 14. I can't get under 10.
Okay. So the average delay of transversus abdominis in somebody with low back pain is zero point 0.8 to 0.12 seconds. Now, it's a delay in activation, not a no activation. Now, in neurological terms, this is an eternity. Okay. This is 80 milliseconds is a long time. It's statistically significant, put it that way. But clinically, if you honestly think that you can tell the difference, you couldn't even tap that fast. If you can honestly think that you can tell the difference in the activation of transversus during a functional task like lifting your arm quickly, and you can tell the difference between 0.08 and 0.12, I think you don't have a concept of how quick that is, right? That's why I use this stopwatch app. That's a delay in activation, not the absence of activation. It's a delay in activation. And we think our itty bitty exercises with a deep breath in and breathing out and controlled contraction and all the rest of it, we think that's going to be the massive difference that restores it. And the thing is that in the research, it shows that. It shows that when you do these exercises, it does change the activation thing. But when you look at the wider research, doing those transversus activation in low back pain people with low back pain, there's no difference on average to any other modality, including general exercise. And you're going to find that for some people, it is the bee's knees. It's the thing that they needed. So it's helpful to have. I gave somebody a multifidus activation. It was the only thing that helped him. Multifidus activation. I told him, I don't remember the last time I had somebody that I needed to do a multifidus activation for. And he had to use it for less than a week, and then it was done. None of this business of back pain, by the way, he's doing quite well. None of this weeks and weeks of having to learn how to do it. As soon as he got that multifidus activation, we were loading with that activation. Like, you don't have to sit around for 6 weeks doing these itty bitty contractions. Like, why can't you just start moving? So, anyway, I can go on and on about this stuff.
I could hear it forever. I think it was honestly, it was a push, even from one of my students, and that's the kind of story we tell ourselves that if we're getting people better, then why change anything? And the story there is whether or not people are getting better because of us. And I think that's the greatest story ever told is we think we're fixing what might not be broken.
Yeah, or we're breaking things that aren't broken. And what if what you're doing helps, but the reason why it doesn't? For example, back in the day where the fires of inflammation in your joints required a cooling drink like willow bark tea to help, so people used to have willow bark tea to put out the fires of inflammation. And modern science tells us what's in willow bark. It's salicylic acid, aspirin.
What aspirin is.
Like, aspirin is an anti-inflammatory. Now, does that mean that it's actually the cooling properties of the willow bark that's the thing that's helping? Or is it actually because it's an anti-inflammatory molecule that's being used to help? Like, I think most people are okay with a scientific explanation as to why willow bark tea helps, right? Why can't we do the same? Hey, this stuff is what we do. Here's why we think it helps. Let's challenge the reasons why. I never challenge that they help people. If you tell me that you help people, I just believe you. I believe that everybody is actually good at their job. You're going to have to prove to me how bad you are as a therapist or a trainer before I believe that you're bad, right? So you don't have to prove anything to me, number one. Let's look at the reasons why. We can change the reasons why without changing what we do. And then once you change the reasons why to something more scientific, I know that your behavior will change as well, right? Because once you realize that you don't have to have people sitting around for 6 weeks doing breathing on the floor, you go, well, what are we lying here? And maybe they do need the rest. Honestly, early postpartum, I have no problem with people lying on the floor doing exercises, doing the itty bitty exercises, because honestly, modern parents are just overworked. There's not the village support that used to be there for people. So many people are on their own. And, back in the day when people went to church, like they'd have church come through and provide food and support and help clean the house. Like they'll be their family for them. And now so many people don't have that. Like, what do we have left? If you belong to a sports club, you might get lucky. But do you know what I mean? Like, we don't have the same social networks that we used to. So it's important to recognize, in the West at least, that a lot of people are isolated and their providers become their support. So I'm not against the itty bitty exercises. I'm against telling people the reasons why are something that they're not, right?
Right. Antony, I have to thank publicly the acute care therapist that sent me that post that you made about crunches after C-section or whether it was in the hospital, because those are the therapists that I've been teaching, those who want to help, women like my niece or whoever, if they had a C-section, if they're struggling getting out of bed, they have something a little bit more that's going on medically. Here's a population that's, grossly underserved, at least here in the West. And The reason why they brought me or my attention to you, I think it was an important one because it was kind of at a crossroads that I was facing with, am I teaching people itty bitty exercises really not helpful to get these people through the first 6 weeks and beyond? And so the deep dive that I've done into your work has convinced me I want to see it here in the US, and I'm opening it up to people who are watching. If that's something that you feel you would like to know more about, how to treat individuals with diastasis recti, and how to actually think differently about the interventions that we've all been taught really to give to this population early on. If you're seeing these individuals early, like I am, within the first 24 to 48 hours after birth, and acute care therapists who are not pelvic health trained, if you just want to understand different perspectives, I'm going to say quite publicly, I'm signing up for this course, but I really would love to see it here live. I would love to meet you live and really talk about these cases that we're seeing so early on. More and more women here in the West, Antony, they they want intervention sooner. And that might be, again, maybe it's aesthetics or maybe it's back to function, but they wanna start therapy a lot sooner. So I think you'll have a new clientele population out of acute care therapists who wanna take your course.
Well, I'm happy to bring it, and if you want me in Colorado, let's shoot me an email and let's organize that, right? And hopefully we can get some 0 to 6 week post cesarean, postpartum, and I can show you what we're doing so that you can see. And lots of people think that, look, on social media, you have to talk a big game, all the rest of it. And I am naturally contrarian, so it's not that unusual for me. Lots of people think that because I'm confident that I'm reckless. And yet most people, when they see me work as a therapist, they're genuinely surprised at like how caring and compassionate I am. I literally had people say, all the talk that I've heard about you is that you're arrogant and you're this and that. And it's like just watching you with that patient was different. Like, it's like, okay, I don't know where it comes from. Like people get upset. So yeah, anyway, I would love the opportunity to do something like that. It's just the application of principles, right? It's the application of principles. There is a course, there's a foundations course that goes through a lot of the principles. So
Of
that's
course,
something
is
as
that
well. It's called the Peak Simplicity Foundations course. And so, that's on my PT education. I think it's 75 US dollars. Shoot me an email. I'll make sure that people get it. If they mention you, if it's not 75 already, I'll make sure that it is.
excellent.
Or it might be
That's it.
cheaper. It might be 50. I don't know. But yeah, it's just the basic principles that you can apply to any case. I've used the same principles with Olympians, elite special forces, world champions, all the way through to the very infirm and the very like literally fragile. So the principles apply across the whole population. They're not particularly complicated at all. And just because they're simple, it doesn't mean that it doesn't run deep, right? So that's important. And also on the crunches with the cesarean thing, I, out of fear, did not mention what I do just because I was scared. But Taryn Hallam mentioned it. She's a pelvic health educator. She mentions her own experiences with crunches and sitting up. And it's like, "Oh, good. I feel like I got some cover because people really respect her, like, so I feel more brave to talk about what I've been doing for 2 decades, 3 decades. But yeah, anyway, happy to show people that. Let's get me to Colorado. We'll go from there.
Let's bring you to Colorado. Antony, thank you so much for your time.
Thanks for having me on